guys, welcome back to the Teen Sessions podcast. My name is Eboni Harris.
And I'm Elisa Mokeen, and we are two brown chicks changing the face of therapy on both sides of the couch.
Thank you for joining us. This week we have almost Dr. Ewune.
Doctor and a half.
And yeah.
Half doctor.
Half doctor. That's why I was like, do I call her doctor? Okay, let's say doctor.
I do that.
You're an LPA right now.
Yes, I am.
Licensed Psychological Associate.
Correct.
Okay. And so we're going to chat with her about health disparities. And of course, we're going to talk a lot about Black and Latinx communities. So before we get started, we were talking because we didn't realize that you were in private practice when you were in school.
Yes.
So tell us a little bit about your journey. You've been in school and then what you're doing right now with private practice.
So I've been in school for several years.
Yes. But you decided to be a PhD. That's what happens.
The PhD is a really long road, but it's been fulfilling because honestly, what I want to do, this is a path I have to take.
Mm-hmm.
And so I try to really keep that in mind. There are some dark moments where I'm really, really discouraged, but overall, I'm really fulfilled by working with my clients and making the differences that I sought to do when I went for this degree. So in our program, well, how do I start? I guess there's something called the EPPP, which is an examination for professional practice in psychology.
Okay.
And it's the national licensure exam for all psychologists. And basically in each PhD program, we have comprehensive exams, and they're made to look like the EPPP, but it's not the EPPP.
Mm-hmm.
And within the last 2 years, our program decided, would you guys like to take the actual one since you're doing all this studying for a test that's just like it? It may be better to just apply that knowledge that you have to the actual exam versus you do the simulated exam, graduate, and then try to study again.
Oh, yeah.
And so a lot of students voted yes, of course, and even though it's an expensive process, like it's very helpful because you use the information that you have as a student versus being a working professional and trying to find time to study for a very expensive exam. So when you take the exam, we had to test at the doctoral level. So there's 2 different levels for the LPA, but for it to count for school comprehensive exams, then we had to test the doctoral level, as well as complete the Texas jurisprudence exam at the doctoral level. And then we're able to get licensed, and it counts for school as well. And it's actually a double bang for your buck, because while we're also licensed, once you graduate, you just put in your paperwork with your degree and your hours, and so you don't have to take any more exams if you're staying in Texas. So that's how that process got started. And considering I've been in school for so long, I was just ready to kind of get out there and leave the student life behind as much as possible and really start getting into being a young professional. And then I went to some of your events. As I was in mental health and was able to coordinate and network with different people. And when I was ready to be licensed and look for employment opportunities, I kind of utilized those resources.
Oh, I love that. And we didn't even know.
Yeah, we didn't know.
She was like, yeah, I met that person at one of your events. We're like, yay!
So I'd like to you now being in private practice, and are you able to collect hours now?
I can.
Okay.
I can. So I'm no longer collecting hours for school, but I can collect hours that would count towards my full independent licensure.
Okay.
Sweet.
So an LPA, once you're licensed initially, you cannot practice independently.
Right,
so you still have to kind of connect with the licensed psychologist every couple of weeks and discuss your cases with them. But after about 2,000 hours, within 2 years, then you're fully independent and you don't have to check in. So that's when I'm counting the hours.
Okay. As an LPA.
As an LPA.
Oh, I didn't know that.
Yeah, so that
Fantastic.
just started last year.
Okay, because that was the only reason I didn't do LPA. I got my master's in psychology, and they were like, well, you can become an LPA, and they were like, but you just have to work under a psychologist forever. I was like, well, no.
Forever.
Yeah, she said they just changed it last
You're
year.
going to change your mind about going?
I'm done.
I mean, I have material for the EPPP if you'd like to.
You want to study for this? I have 2 already. I'm good. Awesome. So you said for what you want to do, this is the route you have to take. So what are your goals as far as like, how do you plan to change the face of therapy or work within minority communities, or how are you already doing it?
So I'm already doing it by being that person. So what I mean by that is I'm always that person in the classroom, that person in the conference room discussing our cases for the day or for the week, who's always bringing up multiculturalism. Even though in counseling psychology, that is one of our main strands that we stand on, I kind of feel that most of my colleagues utilize as an afterthought. Like, let's put the plan together, and then they're like, oh, this person is whatever they are. But I don't think that's being used in the actual treatment planning of individuals. And I think with certain populations, that should actually be at the forefront. because how they perceive things and how they've experienced life
Mm-hmm.
completely differs from that of another person. And so we have to kind of look at that first, in my opinion,
For sure.
before we kind of decide what could they even benefit from.
Right.
What would they even identify with?
Right.
So I am that person.
That's awesome.
And I see that's a big need, especially within the African diaspora. I feel like they tend to overgeneralize Black people as a race. It's like, well, they're Black, so they are this.
Yeah.
And while there are similarities, there are some core differences too within different ethnicities and cultures, right? So we have like Africans who just came to the United States. We have people who've been here for several generations.
Right.
We have Afro-Latinos and Latinas.
Mm-hmm.
You know, we have people who've lived in Europe when they came over. And so
Right.
it's a completely different experience as a Black person.
Right.
And sometimes if we overgeneralize them, we're going to be missing some key things that we need to treat them effectively. So that's what I mean by I am that person. I'm like, hey, you know, this person is, for example, I think we once had a client who was a refugee from Sudan. And so there were some major multicultural competencies lacking between the therapist and the client, and I kind of brought that to her attention. I'm like, I'm kind of hearing some things, but it sounds like we're just not on the same page culturally. And you're kind of seeing them or viewing them through Western eyes, and that's why they're presenting as this. For example, like eye contact. Not all cultures are comfortable with direct eye contact. And I recall her saying often, well, she doesn't look me in my eye. She doesn't look me in my eye. And I was like, well, for her, that's a sign of respect.
Yeah.
Because that could be aggressive to look a person in the eye. And she's respecting you, that she's going to look down. But that for her, the therapist, that was a problem. And then even talking about like physical abuse from parents. There's different ways to discipline your children, and cultures kind of see it differently. And so before we kind of go into a right and wrong conversation, I think we have to be just cognizant of different cultures have different experiences with raising their children or different practices.
Right.
And so when I brought that to their attention, I was like, you know, even the blending of the families is different across cultural lines because she wanted to work more with the stepmother. And I was like, in this culture, the stepmother isn't really involved with the child because that's not her biological child. So those are certain things that we need to know. And so just kind of being that person, like reminding them that like people are different and we have to be aware of that. We can't just consider multiculturalism as an afterthought. It has to be at the forefront. So I'm that person clinically. And I know people get tired of me. They're like, oh, here she goes. Yes, here we go.
Right.
Well, you must be tired of it though too.
Having to be that person.
Sometimes I don't want to be the representative, because I don't know everything. But I just feel like even if I just put that thought in the air, I feel like it's helpful. And if I don't do it, who's going to do it? And I'm going to sit and feel really conflicted about that. So I don't mind, but ultimately my professional goal of why I wanted to get the PhD was so I could be an independent practitioner and a researcher. So it's not enough for me to just talk about these things because I'm only one person in one room. And I think we need to have more research that focuses on these cultural competencies for therapists and disseminate that forward. And so we don't have enough. Like there are some people doing the research, but they're far and few in between. But I would like to join those forces and be able to put out information. So when I say something, you can actually go look it up. You don't have to take it and say as bond, you know. Then also just kind of staying on the ground level and connecting with the people. I think it helps for people to see someone who looks like them, someone who understands their culture. So hopefully the goal is to merge those two.
Yeah.
I love that.
Now that's awesome. And I love what you're saying about the not putting on a back burner, because I think when we present cases or talk about cases, it's very much like these are the behaviors, these are things they're going through, and we're not always talking about the person and their experiences and their life and their culture and how that impacts the decisions they make or the things they're going through. Because even working with couples a lot, I noticed since my clientele has went 99.9% minorities, the way that they present their issues is completely different. And the issues that they present are completely different. And I'm always curious, and I don't, I guess, have a lot of white colleagues that I just chat with about my cases, but I'm always curious, like, how they would perceive that if this client or this couple had presented to them, what their view would be of it and how they would approach it differently, and maybe go a little bit too far and not pathologize it and things like that, as opposed to, like, these are the experiences they've had, culturally these are the way things go sometimes, and so then how do we treat them based on that, and not based on what the majority is saying is normal.
Exactly.
So I think that's awesome. That is the priority. Like, let's put this first. Let's not wait and say, these are the behaviors, these are the issues. Oh, but they have this going on. You know, so how does that impact after we've already decided that this is how we should treat them?
Exactly.
Yeah, that's awesome. That's really awesome. So as far as the disparities in health research. Like, tell us about some of those. Like, what are the disparities, and where can we make a difference? I guess.
Okay, so one thing about me, I like to call myself like a research junkie. I love to research.
Okay.
You know, I'm a nerd at heart. I love to ask questions and find answers. And the focus of health disparities research is to identify why there are significant differences between major communities.
Mm-hmm.
One project we had, we're looking at obesity and nutrition. And so typically when we discuss those things, we're like, well, the person's just not eating right.
Mm-hmm.
Or they're lazy, they're not working out. And actually from that study, I learned that there's far more that goes into obesity than what we really think about.
Sure.
So in that aspect of health disparities, we know that like African Americans and like Hispanic and Latino populations tend to be more obese.
Mm-hmm.
But is it because they're lazy?
Mm-hmm.
Is it because they're not eating right?
Mm-hmm.
And actually found like there's a little bit more to the story. And so one of the things we talked about was food deserts, right? Like what is available in their area. So most of the areas that we looked at that house these populations only had corner stores. So you know corner stores have a limited amount of inventory.
Nutritional.
Exactly.
Yeah.
So that's one thing. And then another thing we saw was are the neighborhoods safe for them to even walk around in, right? Because there's no gyms in the area.
Right.
So we say, well, just walk outside. Yeah, just walk outside.
Right.
But there's a neighborhood safe for them to walk in.
Right.
Most of them didn't have safe neighborhoods for them to walk in. And if they were safe enough, do you have sidewalks?
Right.
So people don't have sidewalks. And so when you really look at it, and it's not creating excuses, because when I've discussed this with other people, they're like, well, those are excuses. And I'm like, no, we have to look at the circumstances before we make a judgment. Right? Because if we had all these things and we still didn't do it, then maybe we can start talking about, you know, if they're lazy or lack of ambition, motivation, those type of things. But we don't even have the basic necessities to even engage in those type of activities. You know, so like there's no sidewalks, there's no safe neighborhoods, there's no parks for the kids to go and play. You can't even take the kids and maybe play with them. There's no food in the area. So that is what's actually contributing more so to obesity rather than the lack of physical activity and poor nutrition. So, and then that kind of goes into like policy. So what can we do to ensure that we can support people? Like we need to have sidewalks in all neighborhoods. We need to maybe make sure we have a certain grocery store that has good nutritional quality. Because even there are some grocery stores like in Houston in certain areas, we know that the meat is gray.
It's completely different.
You know, the flies, they congregate around the produce. So even then when there's a grocery store, we need to make sure that there's a certain quality that we don't fall beneath for any population. And when we have those basic necessities, then we can start looking at, okay, now that we have these, how are the obesity rates now? How are nutrition rates now?
How do you stay hopeful? Like, researching all that, I'm like, it just feels like so daunting and infuriating, right? And like, so how do you, like, you're on the front line, so to speak, and seeing just how, I mean, like, it's like we know we're aware of it, but to really be studying it, and how do you stay hopeful?
That is a really good question. Do I have an answer? Because I know whenever I go to seminars, I'm just like, I'm so tired of hearing about the plight of Black people and how we're just suffering in every single category. I'm like, like, where are we great? Like, where are we excelling? You know? But one thing I can say, maybe this answers your question, is that I'm actively doing something about it. So I don't feel as though, like, I'm just sitting on my hands getting this information. Like, I am in a position where I am able to ask these questions and go into those neighborhoods and try to find the answers and come up with solutions. One thing I think with research that lacks is we have these answers and like who do we share it with? Because it's only like an academic journal. So has access to that,
Only professionals.
And even with professionals, only people who have access to like university libraries or like hospitals, you know, they can get that. Because they're not willing to pay the fee for those journals and you're not getting that information. And so I stay hopeful by knowing I'm doing something, but also that I have intentions on returning with this information. Like, okay, now that we have this, what program that can we create to implement these findings? And then can we study that program to ensure that it's doing what it's actually do? So there's a lot of steps, but I guess I'm just hopeful knowing that I have the tools to make some change, and I have colleagues who are dedicated to the cause too, and with time I feel that we will be able to do this.
Love it. Love it.
Because I can understand how that can be discouraging, even what you said earlier about like people saying those are excuses and not being able to
I'm like, how is that an excuse?
As a hurdle. Like this is an issue that needs to be overcome. And yes, people do, and some people are able to do it. But if one group of people always has more hurdles than the other one. Why are we surprised that one group of people is suffering more than others?
And it's systemic because it's out of their control.
Yeah.
I cannot build a sidewalk. You cannot build a sidewalk.
Right.
You know, we can't build parks. Those are things that are placed there by the city.
Absolutely.
City funding.
Yeah.
And so, like I said, it goes into policy and systems. Like, why are certain areas getting less funding and support from the county, the city, the state, than other areas?
Yeah.
Right. Okay. So how would that move into like mental health? Obviously, we talk a lot about how Black and Latinx communities either have less access to services or not, seeking services at a way higher rate now, which is amazing. But, just aren't seeking services, don't have access, don't even recognize that they need the help, or whatever. So how do those health disparities impact mental health in minorities communities?
So when you ask that, I kind of think about another project I did for most of my graduate career, which was looking at stress and coping in young African Americans. And so basically what we hypothesized was due to chronic stress that can be from like financial obstacles, educational obstacles, familial relations, or even like racialized stress like in the community or what we see on TV, right? It slowly but surely breaks your body down. Because in our body we have cortisol, which is like a natural chemical that's released whenever we're stressed out. But if you're constantly stressed out, it's constantly running. And the thing about that is cortisol itself, if it's in our body for too long, it can break down our systems. And it also hurts our ability to self-soothe. And so when that happens, that's when, substance abuse and self-medicating come into play. So to answer your question in like a roundabout way, is that I really feel that now there's a lot of self-medicating that's happening, and I think that's really prevalent in like pop culture, like in music, like people talk about it all the time, or even on social media, how people talk about the drug use that they engage in, to relax, but there's a little bit more to that story. And I think it's also even evident in the cases of like overdose rates that are all-time high now, and so I think there's still a stigma of mental health, and I think people think that only certain disorders and certain types of people note treatment. Right? So that is some more chronic, like schizophrenia, bipolar disease, and things like that, versus, like, you still need treatment for anxiety, you still need treatment for depression, but I don't think they know how to identify it until it's more serious than it was before. And so they kind of maybe downplay the symptoms like, oh, when I'm stressed out or I'm just trying to chill, then I'm going to like smoke, for example, and they don't realize that these are the acute symptoms of like anxiety or depression. And so to kind of help people with that, I think even with the health disparities, we need more participation in our research. That's all we need. And so that's another, issue, right? Because a lot of people say, well, I don't want to be a guinea pig. And they saw what they did with Tuskegee, like boys being Tuskegee. And one thing like researchers want to highlight is when there have been a lot of ethical considerations put in place to protect populations now. And we have like the IRB. We didn't have the IRB before, which is the Institutional Review Board. We didn't have that before when all this was happening. Now we do. And so there's different things in place to kind of protect you, and I feel like it's important for them to come in because even though they're coming in, sometimes we have like a really high second no-show rate, so they'll come the first time, then they won't come after that. And I think that maybe because we just don't have all the tools or resources to assist them, or that's not widely available, and I think that if they participate in research, we can see how mental illness kind of presents itself in this population. Because we're still kind of going off of what we know it to be, and like we said, that's more the majority population versus minority populations. So if they can kind of help us help them, I think that's one way we can kind of pull them back into mental health. Like, this is not just for you, you're helping us help you and the next person who comes after you.
So have more minorities actually participating in. And we talk about, I talked about that a lot because on my other podcast we talk about research and sex and relationships. And anytime we do a study, we'll talk about, okay, do you think there were any minorities within the study? Which most of the time it's not, because it's college students at universities that can fund these studies. And typically, for the most part, a lot of the research is like white men, right? And so I think that's important to kind of identify, like, how are researchers working to get more people, minorities, to even know about it? Because if I'm in college and you offer me $50, I'll probably be like, yeah, I'll do it, but do I even know about it? Is that something, are you going to universities that have a higher population of minorities to do the research and things like that? So I agree that we should encourage people to be a part of the research so we can learn more and have the actual documentation, because that's really big. We can always tell people, like, well, this is what's best for you, or this is what you should be doing. It's like, well, how do you know? Well, we don't, because we don't have the information.
Right.
So we know logically, we know what works, but it's hard to say like, oh, here's the research that shows with minority men aged this helps them.
Right.
Because we just don't necessarily have the information.
Well, and I think it's also getting our communities to also understand why it's important.
Right.
Right. Like how it benefits us in the long run and how it works against us to not have that research out there available.
Yeah. Exactly. Because if we don't have the research, then it does impact policy. It does impact when you're trying to make changes within the mental health or medical fields and things like that. If you don't have it, then people aren't necessarily going to listen to you.
Yeah.
That's true. Yeah, it's easier said than done, though.
Yeah.
So I don't want
That's why I wonder how you stay hopeful.
I don't want to be like, well, the problem is you. It's not coming to see you.
Right.
Really, I think on my side as a researcher and those before me, we really have to begin to repair the trust that we build in the community.
Absolutely.
And again, I'm that person who talks about that. You know, in all the recruitment meetings, I'm like, we need to have some type of like town hall or something to kind of address what has happened and like apologize on behalf of our research ancestors, for lack of better words, and kind of just like really try to drive the point home that we are here to assist. Because even if, you know, we have the IRB and the ethical considerations and things, some people are like, well, all skin folk ain't kin folk, right? So just because you look like me doesn't mean you're for me. And so that's why I think we need to go in those communities and really like be there more often to really show that we are dedicated. We're not just here to pull information from you and just go sit in our offices and we don't come back. Because that's something that's happened before.
You're changing the face of research.
No, that's awesome. And it makes so much sense. That's because we always talk about the trust issue with people in authority. Right? So researchers, mental health professionals, medical professionals, cops, anybody that's like
all of it
in authority, there's already that lack of trust there. And so trying to figure out how to, and it makes sense. You have good reason to feel that way. But how do we then show up to show them like this is not the same? And I think what you're saying makes sense. You have to be there. You can't just decide like, hey, we're coming in to get this information and then we're out. You have to show them that like, no, we care about this. We care about this community.
Yeah, and it needs to be a long-term commitment.
Right.
Because in the past, a lot of communities have tried to participate in research. And what they've said is that they come in and they get what they need and they leave. They don't even come back and tell us what the findings
What the results are. Right.
You know, they don't even come back and say, okay, with this information, this is what we plan to do. And so I think it has to be that full spectrum. So you come in, you meet, you realign, you know, you get the information, but like keep them a part of that process. Like, this is why we're choosing this design. Like really explain to them why you're making certain decisions so they feel really involved. And then when it's all said and done, like have a presentation, like this is what we found. So these are the next steps. This is the program that we're going to do, or these are the policies we're going to write. These are the policies
and try to implement that into that community and not move it on to somebody else's community or something like that. Yeah.
Well, it's just like everything else. It's a relationship. Right? Like you're building a relationship and you have to nurture it and the trust and the follow-up, all of that. So it's so much of building the trust is having that relationship.
Right. So if there's students that are interested in working in this area and helping with lowering health disparities and things like that, what can they do? How can they be involved?
Graduate students, undergrad students, I think just to join professional organizations. I think that's what really was helpful to me. Because of course you have your professors, so make it known to your professors who are in this research area, just anyone, because you never know who knows anyone.
Right.
And that's one thing I've learned is that the psychology world is very small. So, you know, let it be known in your school that that's what you're interested in, but then also join these professional organizations. Like people are always looking for students to like help out or to nurture, to groom. There's so many fellowships and scholarships and workshops. You just have to get out there, and most of the time we don't know about it. So I think once you join the professional organizations, you get on the listservs, the information just starts coming in, and that's really what I've done. You know, I just like, oh, I'm interested. How do I get on the listserv? And then that's where the opportunities come through.
Okay.
Yeah.
So just making sure you're
something very
difficult. Exactly.
Just get informed.
Let
people know what you want to do.
And let them know that you're
Open your
interested.
mouth. You know, I'm a big proponent of closed mouths don't get fed.
Yeah,
that's right.
So just say like, hey, I want to do research, and that's how I started undergrad. I was a McNair scholar, and I would speak to a person. I'm like, well, this is what I want to do, and they're like, well, I'm not available to mentor you, but I know someone, and so that's how it started for me. It was just like, okay, I can help you, but I can show you to someone who can. And I feel most people in that situation, they are actually happy to do that. You're kind of paying it forward because we all got here because of someone looking out for us.
Yep. What are your favorite? Sorry.
No.
keeps you hopeful?
You're reading all the research.
I guess engaging with my colleagues, like they really are my support system. And even though we don't speak often, when we do, like, I mean, they're on the same page with you, so that's really reaffirming, you know. And sometimes they're aware of other things that you hadn't considered or other people that can be helpful. So I always go back to like my community, like my tribe, my professional tribe, and they tend to kind of point me in the same situation. I don't really utilize books and articles and things like that,
Right.
But that honestly is not my first go-to. Like my first go-to is to kind of talk to like, hey, have you had this situation? How did you handle it? And they may say, oh, check this book out. That was really helpful for me. Or this person, this article. But I don't like to reinvent the wheel.
Yeah.
So kind of just like put a buzz out and see how people have handled a situation and then proceed from there.
Okay. That's awesome. So, in your words, what makes therapy dope?
So many things. It's time just for you. And that's not something we get that is undivided.
Right. True.
It's unbiased for the most part. You know, this isn't a person who knows you intimately and can say, oh, but this or but that. Like, they're focused on you and they only know what you share. And they see you positively regardless of what the situation is. Yeah. And it's helpful. It's a release.
Yeah.
That's what I tell my clients. I'm like, this is a release. So this is your free space, your safe space. And, you know, I've encountered a lot of clients who say, like, they apologize a lot in sessions. Oh, I'm sorry. So I'm like, look, you don't have to apologize.
You don't have to, right.
Anything that happens in here, you know, this is really for you. So if you need to cry, if you need to scream, like, it's your area to do whatever you want to do.
Right.
And so I think you can't get that anywhere else.
Right.
And that's why it's dope. Like, it's just for you.
Yeah, and it's for you to get what you need. So, yeah. That's awesome. So, what makes you a dope, soon-to-be psychologist, LPA, practicing clinician? Okay.
I care. I am genuine. I really, really enjoy working with my clients. I really love what I do. I consider my profession to be a privilege because it's taken so long and so much money.
So much time.
So much of my youth. Like,
so much of my youth.
My life to this, my 20s, I gave to this.
Yeah.
And so I'm here because I want to be here. So it's not a situation where I'm like, well, I'm here to make money. You know, that's a separate situation. Like, I'm really here because I see the need and I want to help out. Yeah. And I think if you get more genuine people or you get a genuine therapist, like, you can't go wrong with that.
Right.
Yeah.
Thank you so much.
So good. I learned so much.
Oh yeah, that
I want to get active. I want to cry. I want to
do something. But I'm really sad right now.
Right now, I'm through this. Yes.
Yeah. Well, tell people, how do they keep in touch? How do they follow you? If they want to work with you or anything like that, how do they do that?
Okay. So I guess on Instagram would be the easiest way. My Instagram is just JUST_WU, woo, another underscore. That's the easiest way to get in touch with me. Or if you'd like to email me, my email is ewuneewane@gmail.com, and the spelling of my name is on the promo.
Yes. And I'll make sure to put that in the show notes as well. At gmail.com, you said?
Yes, ma'am.
Okay. And then the name of where you practice is?
I am a therapist at Hands of Healing.
Hands of Healing in Baytown, Texas.
In Baytown, Texas.
Right.
All right. Thank you so much for being here.
Yes.
For supporting the event and coming out. And you invited us to be part of that event over at University of Houston.
Oh, yeah.
So,
the psychology panel. That's when we were like, why are we here?
We were like,
this is wonderful. I mean, thank you for even creating the organization. It's been amazing. The resources that I received, just like, again, in the listserv, in the email, in the Facebook, it's been really helpful. It is nice to have like-minded colleagues.
Yeah. Right.
Thank you
awesome.
so much.
Thank you. If you want to be a part of our community, make sure you head over to melaninandmentalhealth.com. Follow us across social media at Melanin and Mental Health, Melanin Health on Twitter. And tomorrow we are having a webinar, but sex after betrayal.
Yes.
If you have not signed up for that, please do. We have about 24 hours for you to sign up, and then we have to cut it off. So go ahead and sign up for that webinar. You can do that at bit.ly/ Did you set up Link is in the Instagram bio. Check out the Facebook page. All of the information is there.
It's going to be good.
Yes, it's going to be really good. We have a pretty good number of people that have signed up, too.
Yes. Renelle Nelson, she is an ASEC sex therapist, ASEX certified sex therapist. She's going to be talking all about what happens after the betrayal. How do you get back to sexy time? So it's going to be good. Don't miss it.
All right. That's all we have today. We'll talk to you next time. Bye.